We can start now. Okay. So, good evening to all of you and welcome to the 40th HJ Mehta Memorial Oration. I know that it was initially planned much earlier and we had to postpone it because of, we initially wanted to have it live and then we had to change it to an online mode and then postpone it because of Omicron and so many other circumstances. But we're very pleased that we are actually having it today, and Dr. Vijayakumar had agreed to join us. So welcome to all of you. A special welcome to Professor Vijayakumar. And so I'm Dr. Maya from the Alumni Association. And I remember when I was very young, my father, who was a surgeon, was also considered an oncosurgeon because oncology was such it wasn't a speciality by itself, and it lent itself to some people just specializing in certain areas of it. And my father was one person who was very, very interested, and I'm sure if he was alive, he would have been very happy to listen to you speak. And I'm sure all of us over here are going to be enjoy this evening. A warm welcome to you, everyone over here, especially my committee members. And I can see Dr. Flossie. So welcome, Dr. Flossie. It's nice to see you over there. And I'm going to hand it over straight away to Sister Diana, who will lead us in prayer, just like we always start all our events with a word of prayer. Yes, Sister Diana.
In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Psalm 34. I will always thank the Lord. I will never stop praising him. I will praise him for what he has done. May all who are oppressed listen and be glad. Proclaim with me the Lord's goodness. I will praise you, Lord, with all my heart. I will tell of all the wonderful things you have done. I will sing with joy because of you. I will sing praise to you, Almighty God. Dear God, we thank you for your amazing power and work in our lives. Thank you for your goodness and for your blessings upon each of us. Thank you for your great love and care that we experience in our day-to-day life. Thank you for your bountiful blessings that you shower upon each of us in a special way to the members of our St. John's Alumni Association, through which we could share your love, care, and compassion to the needy through various ways. Loving Lord, we ask of your special graces upon each of us present for this meeting. Come be with us, inspire us, and lead us in our time together. Lord God, take what we have prepared and multiply our efforts as only you can. Blanket us with your peace, wisdom, knowledge, discerning spirit, and your love. Lead this meeting as thy wish. Let us invoke our God's blessings as we keep silence for a second. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you, Diana, for this word of prayer and how important it is that we always acknowledge God's presence and his wisdom and the opportunities we have all because of him. Okay, so we need to go straight away into the oration background and to give us some understanding about why this oration was started and a little bit background of Dr. H.J. Mehta, who tragically lost his life just outside St. John's gates. And coincidentally, the house that I live in was the house that he used to live in many, many years ago. But Dr. Flossie Jayakaran is going to introduce and give us background on the oration. Over to you, Flossie.
Thank you, Maya. The Alumni Association organizes the HJ Mehta Memorial Oration to perpetuate the memory of one of the most illustrious teachers of St. John's Medical College. Dr. Hasmukh Jethalal Mehta was the first professor to join the college when it started the MBBS classes in July 1963. He was the first chairman of anatomy. He laid the foundation of the Department of Anatomy at St. John's Medical College and built it up into one of the finest departments of its kind in the country. Born on 6 October 1923 in Saurashtra, Gujarat, he had a brilliant scholastic career, topping his class in the MBBS examination of the Bombay University. He obtained his MSc Anatomy from the Gujarat University and then worked at St. Anne's Hospital of John Carroll University and Case Western University, Cleveland, Ohio. He had a love for anatomy, demonstrated by his devotion to the faculty and students of his department. To improve medical education, he spent a considerable amount of his energies to update teaching methods. Though he was known to be a strict disciplinarian, his students loved him and he was admired by his staff and colleagues. His knowledge of the subject was immense and he had an interest in keeping abreast of the allied sciences and subjects of general interest, whether it was the history of medicine, economics, politics, or sociology. Dr. Mehta was constantly exploring better and newer teaching methods. He was an active member of many learned societies that had any bearing on anatomy, human biology, and cytogenetics. He had, to his credit, many valuable papers based on his diverse research interests. He attended many international and national conferences and presented papers. His research interests included anthropology, genetics, embryology, histochemistry, and anatomy. Dr. Mehta was a principal investigator and co-investigator in many of the projects aided by the Indian Council of Medical Research. Even in those days, he encouraged his staff, students, and technicians to publish papers. He died as a result of a tragic accident in August 1973, right at the college gates. That day, the medical fraternity lost an excellent teacher and a man of warm friendship. However, the memory of this dynamic personality, loved by one and all who knew him, is immortal. Thank you.
Thank you, Dr. Klassi, and for that introduction. And what an eminent man who was there right from the beginning of this institution, almost 60 years ago. And again, very personally, my mother and him were part of the first team, with Dr. Sylvie Kamath. So it's extremely personal for us that we knew him when we were very small. We're now going straight to understanding who our orator for today's oration is. And I'm very proud that one of our own alumni committee members, who's a professor in surgical oncology here at St. John's, Rakesh Ramesh, is going to introduce Dr. Vijayakumar to us. And Rakesh Ramesh is not only a surgeon and working in the Department of Oncology over here, but a renowned artist. And some of you would have seen a lot of his sketches and paintings, especially through the COVID and even beyond. So, Rakesh, I'll welcome you to please introduce our orator for this evening.
Good evening, everybody. Can you hear me?
Yes, very
Screen
clear.
is visible?
Yes.
First of all, let me thank the Alumni Association for giving me this opportunity to introduce Professor M.Vijayakumar sir, Professor Surgical Oncology, and at present Vice Chancellor, Enepoya, Deemed to be University, Mangalore. Small problem. Yeah. So there are a mixture of participants. For those participants who are just getting confused with the term surgical oncology, to begin with, let me define the surgical oncology so that things becomes little clear. Surgical oncology is the field of medicine that uses surgery to treat cancer. And Vijayakumar sir is the professor of surgical oncology. Sir's CV is actually very big. I have tried to cut short and summarize it in the stipulated time. So, sir did his MBBS from Government Medical College, Chengalpattu, Tamil Nadu, followed which he did his DNP in General Surgery from HL Hospital, Bangalore. Did his MCH from Kidwai Memorial Institute of Oncology, and he had a training in hospital administration later. Sir also has got fellowship from Royal College of Physicians and Surgeons of Glasgow, then fellowship from International College of Surgeons, and also fellowship of American College of Surgeons, which he received recently. When you think about the professional career of Dr. Vijayakumar sir, he had a small tinge of career in St. John's Medical College in Department of Plastic Surgery and Genitourinary Surgery. When you talk about sir, more than 30 years of his career he has spent in Kidwai Memorial Institute of Oncology, Bangalore, in various capacities, from resident surgeon to professor of surgical oncology. When he took the voluntary retirement, he was the director of Kidwai Memorial Institute of Oncology for more than 5 years, and also the head of the Department of Surgical Oncology. At present, for the last 7 years, sir is the Vice Chancellor of Enepoya, Deemed to be University, Mangalore. Sir is a brilliant surgeon. And one peculiar thing about Vijayakumar sir is that sir tried to adapt in recent advances in surgery, whether it is laparoscopic surgery or robotic surgery. So sir has gone for various training to fine-tune his surgical skills. So he has done his robotic surgery training from Seoul, Korea. Sir has gone to France for learning about liver surgery. Sir has gone to Germany, Heidelberg, for learning about pancreatic surgery, and UK, he has gone to study about photodynamic surgery in head and neck cancer. Sir has undergone various training in various areas of interest in India also, in laparoscopy, advanced laparoscopy, microvascular surgical techniques. And what I heard from his old colleagues in St. John's is that sir had always a passion for plastic surgery. And some of his early papers, if you go through, you will see that a lot of papers are on local flaps. Sir is a lifetime member of Indian Society of Oncology, Indian Association of Surgical Oncology, Association of Surgeons of India, Surgical Society of Bangalore, Oncology Group Bangalore, Indian Association of Palliative Care. In many of these associations, he has been sitting in various positions, and some of the organization he himself was actually in the process of bringing up the organization. Sir has more than 85 publications in index journals, and sir also has written chapters in various oncology books and also in the editorial board of various famous oncology journal. At present, he is the chief editor of Indian Journal of Surgical Oncology. Sir has organized various conferences and workshops in various areas, and he is a popular speaker in various national and international conferences. Sir has received various fellowships. To mention few, he has received a traveling fellowship from Society of Surgical Oncology, USA. Also, he is a winner of Varun Mahajan Memorial Traveling Fellowship, and he has visited Memorial Sloan Kettering, New York, USA. Sir has received various honors from various society, for example, from Oncology Society of Taiwan, from Brazil, from USA, from UK, and also from Canada, Terry Fox Project. Sir has been a part of various research projects and clinical trials. His areas of interest are head and neck cancer, breast, hepatobiliary, and gastrointestinal surgeries. And to mention, one of the landmark trials which he was part of was Terry Fox trial in 2001, which was for head and neck malignancy. Sir is a very popular teacher, and it is a delight to watch students attending Sir's classes and seeing the approach he is making while doing the surgeries, and also when he is doing his rounds. So he is a very popular examiner also. He has almost gone to every colleges and universities, both for MCH and DNB as an examiner. Another important passion of Sir is preventive oncology. So he has been a task force member and chairperson of Health Promotion and Preventive Committee of National Cancer Grid. Under his leadership in Dakshina Kannada, he has done a lot of awareness program for cancer, as well as he has done a lot of preventive measures with the help of local schools and colleges and other social organizations. Another important thing which Sir has done is to standardize the pathological reporting in India. He has spearheaded the task in Karnataka, and he organized the traveling school of oncopathology in Karnataka under the auspices of National Cancer Grid. Sir has established a minimally assessed training program through Animal Lab, Simulation Lab, Cadaver Lab Center at Enapoya, where you can see a lot of young surgeons are coming and getting trained for minimally invasive surgery. At present, Sir is in the program of setting up a state-of-art comprehensive cancer center in collaboration with Tata Trust, Mumbai at Enapoya, Dept of University, Mangalore. There are a lot of achievements and awards for Sir. To mention a few, in 2001, Sir has received the Professor Emeritus Award from Rajiv Gandhi University of Health Sciences, Honored Surgeon 2021 from Karnataka State Chapter of Association of Surgeons of India. He has won Dr. Mahadevan Award from State ASA Conference 1994 and Best Paper Award back-to-back many years from Surgical Society of Bangalore. To summarize in a nutshell, what is Dr. Vijayakumar Sir? He is a great teacher, a popular examiner, excellent clinician, beautiful surgeon, a mentor, great administrator, great visionary, leader, a family man, a friend, and a human being. Whether in a classroom or in a boardroom, Sir believes in systematic and sincere approach of problem solving. He believes in sharing of knowledge and also gaining knowledge. Here he is seen with Padma Shri Devi Kannan Sir in one of the meetings. This is one of the traveling school of pathology programs in which Sir was there along with the other doctors. This is a fully loaded robotic surgery theater in Kidwai Memorial Institute of Oncology. Here, hundreds of surgical residents are being trained in a government oncology center. That was a brainchild of Dr. Vijayakumar Sir. Not only the residents and the clinicians, but people from the lower strata who requires a robotic surgery now can afford to go and get operated. When in 2015, most of the hospitals were dreaming of what is this robotic surgery, Sir has planned and made sure that a robotic OT is there in a government regional cancer center in India. That is one of the biggest achievements, and still till now, I don't think many regional cancer centers in India has got a fully loaded robotic cancer center. With his leadership and administrative skill, Enapoya Deemed University is climbing the ladder very fast. Sir has got a very good relationship with his associated departments, either with the older generation or even with the younger generation. Sir is very friendly, a great family man, and a super human being. This photo was taken in one of the conferences before COVID in Tirupati, where many surgeons of different generation and with their families attended. On the right of Sir is Padma Shri Professor K.S. Govinath sir, and sitting in front of him is Professor Suresh Manjunath sir, who is also Vijayakumar sir's student, who was instrumental in starting the surgical oncology program in St. John's Medical College. I wish good health for Vijayakumar sir for all the work he is doing, and I sincerely wish that his great work is recognized by the people, also by the government of India, and I wish him, the government of India, give him a Padma Shri for his great work he is doing for the development of oncology in India. Once again, thank the organizers for giving me this golden opportunity for talking about Vijayakumar sir. Thank you.
Thank you, Rakesh. That was a an excellent introduction to Professor Vijayakumar, and very impressive to hear, so many accomplishments that you have, Professor. And before I ask you to start the oration, I just want to welcome our Dean, Dr.H.J. and several of the other doctors from the management. So welcome to all of you and all the participants who have joined us. And we are just in time to start the actual oration, where Professor Vijayakumar is going to talk about surgical oncology yesterday, today, and tomorrow. Over to you, sir. The floor is yours.
Thank you very much. No. Sharing this slide now. Yeah. I hope my slides and voice are clear.
Yes, sir. Go ahead. Yes, very clear.
Thank you. Good evening, everybody. At the outset, I should thank the organizing committee and the St. John's Medical College Alumni Association for giving me this honor and opportunity to be the orator for the 40th Dr.H.J. Mehta Memorial Oration. I'm very delighted to be doing so. As I said earlier, I would have wished to be in person, meet you, but unfortunately, due to COVID conditions, we are at least able to meet virtually. Thank you very much. When I gave this topic, I was told by one of the organizing and the executive committee members that there will be a mixed crowd. You don't go deep into surgical oncology was the warning given. But so I don't know where to start and how to go about it. So as usual, I am starting from the zero level, starting what is surgical oncology. I hope to do justice, but I promise you I will not go very deep. My oncology colleagues may say it is superficial, it's okay, but I will go as broad as possible and a reminiscence of what has been going on yesterday, today, and tomorrow, taking my own experience of the last 42 years. Surgical oncology is a unique specialty where the surgeon has to not only remove and go, but he himself has to reconstruct and later he has to rehabilitate. This is the way the surgical oncology, I look at it. And when you see this, you will be wondering what is there everybody has to, when you resect, you have to reconstruct. That is not the way. In oncological defects are so big and so unique and different places, one needs to reconstruct and later on rehabilitate in such a way that individual goes back to his family and society as normal as possible. Then who is a surgical oncologist? A surgical oncologist is one who has to perform unique and complicated surgical procedures, no doubt. But in this background, one has to know why a disease-based specialty at all evolved. We have to go back to the 1960s at least to know what happened. It was a necessity. Nobody was giving a specialized care. Those days, only medical colleges were on the top and they had their own volume and priorities, and specialized training in surgical oncology was not available, and hence the patients suffering from cancer were not able to get a proper care. And you know our surgery friends, their ego, they want no mortality against their name, no morbidity. Unfortunately, those days, cancer surgery necessarily carried some amount of morbidity and mortality, and hence they were shying away from cancer treatment, the form of surgical oncology. that is where the birth of surgical oncology came into picture. You will see when I say this, the standalone centers were very few other than cancer in those days. To name a few, the Tata Memorial Hospital, Mumbai is more than 75 years old, and Cancer Institute, Adyar, Chennai. They all started as a standalone cancer centers. And if you look at it, they are the ones which are only for cancer as a disease, because it's a unique problem where not only surgery, but other forms of treatment has to be there under one umbrella. And that is what they did, which they felt a necessity at that point of time. Wearing the spectacles of 2022, we cannot be seeing surgical oncology of this yesteryears. That is why I thought I'll just give an overview before knowing what is happening today. During 20th century, that the surgery was mutilating one purely anatomical, because there was no scientific rationale. It was something obnoxious, so they removed. Though you cannot ask them why they removed and what they removed, because it should not be there, and so they removed. But over a period of time, anesthesia, asepsis, and blood transfusionology improved so much that they could do safe surgery, and that's how it improved. But the more importantly, certain other factors came into picture, like tumor biology to the imaging, etc., which changed the scenario of surgical oncology as what it is today. Let us quickly see what happens. If you look at tumor biology, no one can talk about tumor biology or the changing face of cancer surgery without mentioning two names. At least one name is William Alston, whom we all know. During his days, there are problems, and he was one who started the cancer surgery as a part of the, based on the pathological spread. What do I mean by that? In the pre-Halstead era, as I said, there is no scientific rationale, but they were removing the disease as it was not to be there. But during his days, the tumors were said to be spreading orderly and in a centrifugal way. What do you mean a centrifugal way? From the tumor spreads everywhere in all the three directions, and the embolization was not known. They thought that it is a localized disease which is spreading everywhere. This was the basis on which the pathology was working at that point of time. And they thought the lymph nodes were barriers to spread. And hence, William Alston devised and designed and popularized an oblong or so-called total removal of the tumor and extended areas, including the lymph nodes. And hence, the patient outcome was totally decided by the surgery and the type of surgery he did. Then came the next person who challenged the theory of local spread and the centrifugal spread. That is Bernard Fisher. He said that tumor spread is not an orderly pattern, but it can grow anywhere, anytime. In fact, he used the word canceremia, meaning cancer cells are already spread in the blood. It's a question of time. They home it and they develop metastasis. The moment the size of the tumor becomes more than 1 centimeter. And hence, he said, however big your surgery you do, the result is dependent on the natural history of the disease and the aggressive nature of the disease and the metastatic potential, and not because of doing big and bigger surgery. This changed the whole scenario of today's cancer surgery, which has become a multimodal in treatment. Meanwhile, the pathology was also changing. The face of pathology has changed so much at that time. During those days, they just said a diagnosis whether cancer or no cancer, and using only light microscopy. Whereas today, the surgical oncologist, medical oncologist, radiation oncologist, whoever it is treating cancer, depends on the pathologist only. The pivot of the oncological treatment is pathology, around which the wheel of the onco treatment revolves today. Having understood this, then it is easy for us to understand how to use them. Earlier, it was only diagnosis. Today, they are talking about prognosticating. They are talking about predicting. I'll just give a small example to make it lighter. In my olden days, every postmenopausal woman would be getting tamoxifen in CF breast, and premenopausal women will go for oophorectomy, say for example bone metastasis. Today, it is the IHC immunohistochemistry is done. Only when the estrogen receptors are positive, we are going to treat them with hormones, otherwise no. So this dictation comes from the pathology and not from the patient side. And one area where it totally changed is in lymphomas, for example. Today, the lymphoma treatment is totally dictated by the immunohistochemistry, where the marker for it, CD20, should be positive. Then we will be adding everything. Otherwise, we will not. You should be worried that the pathology is the basis, and that is why I started looking at pathology. And as Dr. Rakesh said, thanks to some of the colleagues from Kidwa and St. John's Medical College Pathology Department, we could successfully run the training for the budding pathologists in cancer surgery with the help of National Cancer Grid sponsoring the whole program, what we call it as Traveling School of Oncopathology, where we moved across the cities and we went and trained them mainly on the basics like grossing and the necessity for proper formalizing it and the where and why we have to do these things. We explain to them by showing them how to do. It's an hands-on experience. Next comes the role of imaging. During my days, there is nothing other than a plain and contrast X-rays. My age group people will know. And those days, the only way to know this many times is to do an exploratory surgery. In fact, the dictum at that time was, cut it out when you are in doubt. In simple English, when in doubt, cut it out was the dictum, because there is no other way of knowing it whether there is a problem or not. To just give an anecdotal case of my own, the 40-year-old gentleman coming with the signs and symptoms of subarachnoid intestinal obstruction. Those days, there was nothing, as I said, other than contrast. We went and did a contrast X-ray, and it showed a cutoff at somewhere at the sigmoid and rectosigmoid. And so our diagnosis was cancer. But the scopy could not go beyond, because those days there is nothing called flexible scopy. It was rigid scopy. It was not reaching. And hence we have to do an exploratory surgery. When we did, our anatomical diagnosis was right, meaning the imaging was correct where the obstruction was. But the cause of the obstruction was interesting. It was a band, peritoneal band. There is no malignancy. In fact, in a lighter tone, that turned out to be my first ever paper I published as a rare cause of intestinal obstruction. It turned out to be the Lane's first and last band, we call it, because the peritoneal band at that point was considered to be the first one to be embryologically starting and the last one in the GI tract. And so the Dr. Lane called it as first and last band. So these are the days which we have gone through. No endoscopy, no CT scan, MR, ultrasound. But today, we all know that without an ultrasound or CT or MR, we don't open. And we don't decide anything without an imaging. Not only the site and the extent of the imaging can be made out, but even the removal or not removing, we decide. It guides us for the biopsy and the needle aspirations to know preoperatively what is happening. And now the functional imaging has come, which is helping us to change the response to therapy and recurrences. When I am talking about functional imaging, I'm talking about PET-CT. And today the surgeon is better informed prior to surgery. When I am talking like that, we have to see the other side also. This is a classical example I am showing what it was during my days, just a barium swallow on your left. That is showing the stricturous disease. On this side is the PET-CT. I am not propagating PET-CT, but I am criticizing in this case my resident. An enthusiastic or over-enthusiastic resident went and did a PET-CT and came and showed me, look at this, sir, supraclavicular nodes. This you could not have picked up by any imaging. Because of the PET-CT, we picked up, he said. Typical of me, I said, you could have easily picked it up if you have done a proper examination. And you know, left supraclavicular regia is a regional node for any The diseases in intrathoracic, it will come through the thoracic duct, you know it. You have missed it and you are trying to give an excuse for doing a PET CT, I said. As expected, my resident was very unhappy. We'll go on to the principles of surgical oncology. As I said, because of the reasons which I said about Halstead thesis of hypothesis, we were thinking you do bigger and bigger surgery, you will get better results. That was the theory. As I explained, now the thing or the pendulum is swinging to this side. We are looking at lesser surgery, more comfort and better result. That is our aim today. How we are able to manage? Because earlier, as I said, surgery was the only treatment or main treatment. Today, it becomes a part of the multimodal treatment, which includes systemic therapy and radiotherapy as well. And those days, even today, I feel cancer control was our only concern. We were not worried about what happens to the patient socially or even by cosmesis. Our only aim was to treat him so that he lives well. But today, we are looking at cosmesis, function, quality of life, apart from cancer control. The only difference is the typical old timer I am. Even today, I feel cancer control is the most important one. To give it in a lighter vein, if somebody comes and tells that the cancer, look, I want to have a drink, you must allow me. For that, he should be alive first. He should be able to swallow first, and then only I can allow him what he wants as quality of life. In other words, the step ladders which we are taking should be first and foremost one should be cancer control. If we are able to do that well, then you go to the function and cosmesis, not the reverse. But some of my younger colleagues think cosmesis is more important. So I am confused. So I sit and talk to the patient what he or she wants and then decide what should be the first control, whether it is cosmesis or cancer control. That is philosophical. Now look at the science. What is happening in science? For example, in the breast, radical mastectomy of William Halstead has gone, as I told you. Even the modified radical mastectomy, all type 1, type 3 is going. We are looking at organ preservation and we are looking at preserving the organ so that the patient who is a lady is very happy about her body image, rather than only talking about disease and life. Today, they are very happy that we are able to do that either with reconstruction or by conserving the breast itself. We'll go on to see something more. Look at the rectum. 100 years ago, Miles said APR is the standard. Today, we try to preserve the sphincter as much as possible so that the stoma can be avoided. Why stoma can be avoided, you may know. I just go back. Dr. Rangachari was supposed to be the first one to have done APR in that time, Madras Medical College, Madras University. At the end of 4 weeks after his discharging the patient, he saw him in the casualty, having consumed poison for attempting a suicide. When he went and asked why you did so, he said, my family did not accept me with this stoma. That was yesteryears. Today, we have got very beautiful stoma care clinics. Stoma care is there. And in fact, those of you, if you want to know, we are Estimate India is very much available in Bangalore, in Vayalikaval, where we can get the best of the bags at the least of the price. You are welcome to use it. It is available in Vayalikaval, and I happen to be the vice president for that. The sphincter saving procedures have improved for 2 reasons. One, technically, they are coming a little early, but we are able to reduce the size and the staging by giving them pre-operative treatment of radiotherapy, etc. Reduce the size and go and operate. This is one reason. The second reason is when you go down to operate, it is very difficult technically. That is being taken care of by stapler, and thereby we are able to save the sphincter. In the head neck area, Carroll described the neck dissection again, 1906, to be very precise. Today, we have moved towards selective neck dissection wherever it is required. And during the so-called commandos operation, we used to remove everything the nodal disease, the mandible, even if it is not involved, and the primary disease. Today, we remove only what is involved, and that is how the things have changed thanks to this. As Dr. Rakesh introduced, yes, here I have to remember my bosses of St. John's, Dr. R.M. Sabu, who was the HOD of plastic surgery, and Dr. Norman Gaido, who taught me in 6 months the tips and tricks of plastic surgery, which I continue to use it effectively, probably very effectively. For the first 10 years of my Kidwai, and there was no plastic surgeon or reconstruction, I was called to do that in Kidwai Cancer Institute, both in the academic area and other areas. Now I am trying to show you what we used to do. That is, you see on left of you, one breast is missing, that is chest wall you are seeing, that is the mastectomy. Today, this is the recent picture of what we have done, I have done, where we are trying to not only conserve the breast, but give a shape and size. You can see the nipple line, you can see the way the scar is, it's immediate post-op. So this is called as oncoplasty. This is where we are moving in surgical oncology. From just radical surgery, today we are looking at organ preservation and giving them the cosmetic touch. We'll just see what happens in the bone and soft tissue tumors. As I said in the beginning, surgical oncology is such a specialty where we have to handle head to foot, at least those days. And also because of the necessity, no orthopedic surgeon was willing to do this. They were more interested, even today probably most of them, in only doing trauma, either cold cases or emergency. But nobody was showing interest in doing the bone and soft tissue sarcoma tumors. And that is where the amputation, which that is done by me only, but that was those days. In fact, I have to fondly remember my first ever surgical society presentation from Kidwai was MB pelvectomy. Very proudly I presented because big surgery I thought. In fact, those days, Sir Gordon and Gordon Taylor got his sir because of he was supposed to have removed the patients from the tumor. That is the way they used to present. But today, if I say so, no patient is going to come to me. They expect me to save the limb at any cost. How it is possible today? It is mainly possible because of two reasons. One, because of the superior results from CT, that chemotherapy, and then the availability of something called as prosthesis, which I'll show you. This is my work. You are seeing the upper end of tibia tumor has been removed, and this is called as custom-made mega prosthesis. Here I have to think of the Madras group which has trained me, Dr. Mailwagna Nadarajan, and then Dr. Raja Raman and Dr. J.C. Bose of Kilpauk Medical College. They started doing this pioneering work of getting a custom-made prosthesis. Custom-made means like a tailor-made for that particular patient, we have to measure and send. Because tumors are different, unlike the so-called total knee replacement, which you should have heard of, that is easy surgery. We just open up and scrape the worn out cartilage and put in plates. Whereas here, the whole tumor has to come out, and you can see the picture. This is how we used to do. And this was done in Kidwai, and I continue to do that here in Yanapaya, where this is a humerus, where we are to remove the whole thing because it was wrongly placed and the patient did not come in time. So whole bone has been replaced with the custom-made prosthesis. Having said, you will have to see the results. Otherwise, you will think I'm only showing what is required is only to show. See, this is the third day he's able to do. This girl is another patient who is very, very enthusiastic because many people told that she will have to lose the limb. This is my good old ward, Charaka ward, it is called as Kidwai. You may be wondering why I am showing the face. That is with her, and her parents told me, you should show the smile in the face. And she's able to walk on the 10th day, although with pain. But the happy moment for me was when she came back to invite me for her marriage. The technology in surgical oncology is moved leaps and bounds, I'd say, in surgery, which we adopted in surgical oncology also. During my days, there are only catgut and linen. Today, we have moved to other issues like staplers, and then we moved on to laparoscopy and the robotic surgery. intentionally I'm showing this picture where I have to tell it's a teamwork. And this is my team in Enopaya, where we have established the robotic surgery. And I'm very proud to say we are the first one to establish so outside Bangalore and in a private medical college. But the next thing I have to tell is 85% of the patients who have been treated with this have gone cashless, free of cost, which we are able to do thanks to my management who allowed me to do so, and the support which is cooperation given by my team. This is the urology team and the oncology team. We only do that for the last 5 years, and we are able to establish a training center. I was made to go to the Seoul, Korea for training center, whereas Enopaya today has got a training center of their own, where other people come and learn the robotic surgery. When I tell about technology, I am fond of telling this picture because of one reason or more than one reason. How see the poor quality because of the visibility, because it is a single chip camera. Today we have got 3 chip, high definition and 4K, and see the rigid ones, and I am struggling there because that is my first APR in the laparoscopy. Though I have done 400 APRs before touching laparoscopy, I am struggling. This I am trying to say particularly for the youngsters. For the learning, there is no age, no time, and also the technology keeps changing, and we have to go through the painful art of learning, unlearning, and relearning. The unlearning is the most important one, which is very difficult. Relearning is probably easy. Here you see the way I am struggling. Wantonly I am showing this because this is the first case, but still we have to do it. Probably if I had opened it, I would have finished by this time, but that is not the way. If you have to upgrade, we have to go through the painful process of, I am repeating, unlearning and relearning. And you come to this side. This is the robotic surgery esophageectomy done in 2018. I am showing in a live workshop, and you can see the difference in the visibility, in the way the instrumentation is moving. And it's a pleasure to operate with this, but unfortunately it is a very costly instrument. Even to maintain it is very difficult. Thanks to my management, they allowed me to use it for even the BPL patients, and they all went cashless. And thanks to Government of Karnataka for accepting it to give 60,000 or 70,000 rupees, which is not even enough for the medications. But being a medical college institution, I thought it is our duty to help the poor patients as well. You are here seeing the esophagus is getting operated after giving chemoradiotherapy, but you see that is bloodless because we have the visibility and the energy sources. And you may be wondering why the lung is down and the esophagus up. That is how we operate in the prone position. And that is why it looks as though it is down, and see the esophagus vein is being handled. And people who know it, that area so well, that it is so easily operable, and most importantly, without any blood loss we could do. And you need not know surgery for that. It looks as though you are sitting inside the thoracic cavity and operating. So magnified and visible, and that is what the benefit of the technology today is. But unfortunately, what is happening today, the cost of the such procedures are so high, and in a private hospital it may get 4 to 5 lakhs of rupees per the same case, but which we are able to do free of cost for the BPL patients here, and that is because of the medical college setting. I'm very thankful to the management for that. When you say I have got trained, then it reminds me of the training in surgical oncology. Earlier days it was knowledge based, basically. It is basic sciences. We have to learn the surgical oncology training, etc. At this point, I have to remember my mentor boss in general surgery, Dr. Joseph Anthony. He was my general surgery teacher, and later on, I went on to work under him as urology. He used to tell that surgery is never taught, it is learned. I asked him, what do you mean by that? He said, look at the left hand, what it does, and just mimic your boss in surgery. Don't try to move away. It is nothing but observing and mimicking. Of course, those days there were no YouTubes for me to go and see anybody. You have to see only your boss and learn, observe and learn. That was the process. But today, things are changing, the training becoming a difficult hands-on training, and I'll tell you what I have done in the next. So the knowledge-based training is today going towards more of skill-based. Because of the lack in the surgical oncology training, lack of uniform training patterns and the variations in the defining of the specialty itself. And what is happening today is service-oriented. It is head and neck, thoracic, like that. Organ systems have come into picture. They are trying to specialize in one particular organ. Maybe that is the right way to go now. As I said, in 1960s, the necessity was different. Today, the necessity is different. And also the technologically, when you have to get used to this, you may have to probably focus on one area. The generation like mine to doing head to foot may go off. Because you look at this service-oriented, except for bone and soft tissue tumor, everywhere else, the MCH program has been introduced by MCI. MCI introduced MCH surgical onc in 1974, whereas today, recently, 5 years ago, they introduced in head and neck, they are introduced in gynec oncology, already thoracic also has come, not cardiovascular thoracic, I am talking thoracic per se, has come into existence. So there is a necessity for organ preservation, but the training is lacking. So when I went to Korea, I went to Surveillance University to learn my robotic surgery. Then I thought, when one university in Korea can do, why not me in Inapaya? And that is what you are seeing in the picture. That is our advanced surgical skill training center, where the patient lying there with under general anesthesia and where it is going on is not an operative surgery, and the patient is not a human being, it's an animal. It's a live animal. We got the special permission and license from Government of India to do that. And the last 5 years, we are effectively doing it for our own students and also for others. In fact, my MS General Surgery students today have to go through this hands-on training. They have to have the module, and then only they are asked to leave the place. This is possible because of the Advanced Surgical Skill Training Center, which we have established. Today, we have the facility for large animal training as well as for the cadaver specialty. My own perspective, if you look at surgical oncology, I am confused actually after training for so long. Is curriculum-based training superior to non-curriculum-based? What do I mean by that? If you ask me in simple English, my residents who are non-PG residents who have worked with me for 2 years turned out to be better operating surgeons than the MCA students who are rotating through me. That is because I think they are spending more time for the examination preparation and the knowledge-based and not the skill-based. Effectively, of course, even MCA has understood that. That is why it moved. When during my days, it was 2 years MCH program. Today, it is 3 years program. Quickly, we will change the gears. In the surgical oncology is a unique specialty where he has to or she has to learn not only about surgery, but he has to learn about the sister specialties, which are also part of the treatment, like radiotherapy, for example. It all started with deep X-ray. Today, it is IMRT, IGRT, and the machine which you are seeing, thanks to the Tata Trust Mumbai, which Rakesh was introducing. They have donated this, and the high-end, which is called as True Beam, state-of-art, which can treat bigger ones, smaller ones, and stereotactic way. This has changed the whole scenario today in the country as well as in the world about how the surgical oncology is being approached because of the precision, the accurate planning, and less adverse effect. On the other side, you are seeing a brachytherapy machine, again donated by Tata Trust to us, and we are able to effectively deliver surgery because of this paraphernalia. Quickly, I'll move to the chemotherapy part. It's an irony that because chemotherapy or the systemic therapy came very, very late, starting with nitrogen mustard, very few drugs like methotrexate, 5-FU, cyclophosphamide for a long time. Today, it has changed. There were no takers during those days. And so it is the surgical oncologists who are giving chemotherapy for solid tumors. In many centers, it happens even today. And there are few centers where radiotherapies continue to give. But the medical oncology, after the coming into picture with a specific course, and also numbers are increasing. Today, as a surgical oncologist, I am only giving them the access. What you are seeing there is a chemo port. Otherwise, you will be seeing the whole limb becoming darker, black like creeps, creeper will like that, it will go. Today, we are able to avoid all that by putting them as central axis and giving it as a port, which you are seeing there, where the Teflon can take 2000 pricks. Directly, the chemotherapy will go into the major veins, and hence the thrombophlebitis, etc. chances are less. And also, the rescue measures like colony stimulating factor came in, so that we are able to pull the patient out faster, and thereby we can do surgery much more earlier. When you combine both, why not, they thought, and this combination, here I have to tell an anecdote again. One Mr. Venkatesh, who was a peon in government office, came to me in Kidwai and said, "Sir, I have been diagnosed with rectum, but everybody is telling nothing can be done. You have to do something for me because I have small children and I have to live for them." Under examination of anesthesia, when I did, whatever the other person is told is correct, was correct, that it is frozen pelvis. So I had to do only a diversion and came out. And after 2-3 days of his recovery, I explained to him, nothing more could be done. Then again he pleaded, you have to do something. That time I told it was just an experimental therapy, combining radiotherapy and chemotherapy, introduced by MD Anderson at that time. If you agree, it is an experimental one, we may have to do that. He said, do. Then I took my help of Dr. Lokesh, who is a radiotherapist today, is the HOD, and we gave concurrent chemotherapy. Why this story is, it is required for next part. To my surprise, when I examined again after the completion, there was no disease. I couldn't believe that, because that was my first case where after chemoradiotherapy, the disease totally disappearing. Then I got excited, investigated further to find very small residue near the bladder and the rectum, but otherwise it has disappeared. I could operate. So I went and told him, yes, it has disappeared almost, only 5% to 10%, but I cannot preserve anything. When I go to operate, I have to remove everything. This is the best chance. But that means you are going to have 2 stoma, urostoma for urine and the stoma for fecal matter. Are you ready? Again, he said, please go ahead. I want to live for my family. I said, fine. I went and did. Why I said it is, that patient lived for 14 years to die of some other cause. That is not an issue. But he taught me one biggest lesson, that he, whenever he used to come to my OPD, he had a much better and bigger smile than I ever had in my life. He used to walk in. I used to think the quality of life will be poor because I gave him 2 stoma and he cannot perform as a man. I have removed everything. But he said, thankfully, every time he'll say, thankfully, that I am living for my family, you allowed me to go on. That reminds me that I have to change my attitude towards quality of life. It is to be decided by the patient and their family, not by me. This is what I learned from him. And the second lesson is scientific. So I started treating in the same protocol 58 patients at a time, and out of which 12% of them no disease at all after the surgery. Then again, I have to revise myself. Why I did that 12%? Why not you wait? But the protocol was to remove. Meanwhile, a lady surgeon coming from Italy said and made a big article saying such patients can be kept under observation safely. So today I keep them under observation. All these lessons I learned from one patient, Mr. Venkat. Technically speaking, till that time, they thought it was only fibrosis. Radiotherapy gives. Once the chemotherapy is added, it behaved in a different way, and a programmed cell death was probably happening, and everything was disappearing. I said so many things. That means, are we suggesting that everything has to change? Answer is no. Not everything needs to change. For example, the Carroll's R&D, even today we do, though he described it 120 years ago. For large nodes, even today we do. Radical hysterectomy, we do. So everything need not change. Why? You just look at this, you will understand why. I will go there to show why. This is the type of tumor which you are going to remove from the abdomen. What I am showing there is the pelvic deposit so big, that is the uterus, ovaries, pelvic peritoneum, and the sigmoid colon there. Once this bigger disease is there is no way I can save anything there, and the life of the patient becomes so very important. And so this is the answer. We have to do everything to see that the whole pelvis is cleared, and what you are seeing hanging is actually the ureter hanging there, and the rectum has been cut. This sort of pelvic excentricity, which are major mega surgeries, may have to be done at some times, and the surgical oncologist is the right person to do, because he can handle the bladder, he can handle the uterus, he can handle the rectum. And that is why the specialty was popular among youngsters those days, although things are changing, things are changing. Now comes, having said about yesterday and today what we are doing, look at tomorrow. I am not trying to predict. I'm not a predictionologist. But if you look at today, we have to do this, the screening part, the surgical oncologist should take a lead. Why? Because then only you'll get the early stage disease. Why early stage? Because then only you can save the organ and function preservation is possible. The ICMR data today about our country is only 12% of them present to the hospital in the early stage. If you can improve that, then only we can improve our results. Who will do the job? Who will have to bell the cat? It is we who have to do our job. Nobody else going to help us by bringing them early and give it to us. Those days are gone. You cannot sit in the OPD expecting the patients to come early. They'll continue to come late only. So that we have to move. And that is what I requested the Rotary Club of Mangalore, where you are seeing, they donated recently this bus, which has got mammography unit, colposcopy, ultrasound, etc., so that we reach the rural rather than they coming to us. So catch them early so that we can treat effectively. This is on the brighter side. This should be the way to go, is what I feel, and the training should become more comprehensive. And you have to take the lead. That is me talking to the ASHA and Anganwadi workers, and the blue t-shirts which you are seeing is during NSS. We have been training them, and our activities of NSS has been well recognized. And the government of Karnataka, in fact, gave me a project wherein now I am trying to train rest of the whole NSS across the country, across the state of Karnataka, where more than 40 university people are being trained by us. That is in a brighter side. On the contrary, I also feel this specialty may die. From head to foot, as an surgical oncology may die, only to have a rebirth as organ-specific subspecialty of oncology. It will become more and more organ-specific, but the persons who are treating them should become more and more focused on starting from screening to palliative care, and that is what I have established here back in Yanapaya. Surgically oncology of the future, whatever I have written is not a prediction. It's only a dream list and a wish list. Hopefully it happens. This suddenly I am changing the gear for a different reason. This is a tumor which you are seeing easily. Normally or ordinarily speaking, I would have removed it and put a fibular graft. Fibula is removed with its blood supply and placed it in the neck. We'll anastomose the artery and vein so that it lives. This is what we do. But what has happened in this case is the patient has been treated twice because of the recurrence in the ameloblastoma, and they have used the fibula both sides, that is left and right. And she got fed up. She's a paramedical staff coming to me that you have to help. I said, they have already lost both the fibula, what to do? Then she said, again, you have to do. And you see that we have removed the specimen, and the next one what you are seeing is important. That is a 3D printed mandible manufactured in our unit, and then we have fixed it. And what you are seeing, the last picture here, is to see the end result, both the form, etc. This we could achieve because of one reason which I want to share with you. That is because of the NPR technology incubator, which is the very special one, because we are the only two people in the whole country. One is C Camp in Bangalore, another is ours. Why I suddenly am speaking is, if you have an idea, if you have an ideation, we are ready to help you. Whoever is listening to me, either as an institute or as an individual, you please do come to us. We are one of the very few recognized by the Department of Biotechnology to help you, handhold you, more importantly, if you are selected for that, fund you up to 2 crores per project. Am I talking theory? No. We have already funded at least 5 people with up to 2 crores, including one from Tata Memorial, another from IIT Indore. Up to 50 lakhs is another project is there. You are always welcome. You want to become an entrepreneur, you come, you will help you how to make a patent, how to handhold you, because we have got all the facility, including the 3D printing for both metal, non-metal, and the bioprinter facility. In fact, very frankly, one of your colleagues, or at least S12 colleague of St. John's, Professor Chand of neurosurgery, has approached us, and he is working with us to see this, what his dreams are coming through with our Enapaya incubator, and we are trying to help him reach his goal. Before I conclude, I have to remember these 2 institutes. One is the Kidwai Memorial Institute of Oncology, wherein I served for 31 years, and where actually I was born as a cancer surgeon and blossomed to one. At this point, I love to think of so many people who helped me. At least a few I have to mention. One is Dr. Krishna Bhargava, who was the director who appointed me, and Dr. K.S. Gopinath, at the recommendation of Dr. Narman Gaido, accepted me and tutored me and mentored me. And Dr. P.S. Prabhakaran, the then professor and HOD and director, helped me to go beyond the limits of just simple surgeries and chiseled me to be what I am. I'm ever thankful to the institute and the people who are responsible for this growth. Incidentally, as a director, I wrote a detailed project report to Government of Karnataka. Through that, I went and spoke to the Union Minister of Health. At that time, 2013, I wrote this for establishing an oncology wing in all medical colleges, and how much it will cost, how to use the local expertise and the experience. I wrote, it was accepted. So I got thrilled and excited and came and was discussing about it. Suddenly the election came. I don't know where my project. That put me off. At that time, the Enapaya University Chancellor came and asked me, would you like to do that in my place? I said, yes. That's how I landed up in Mangalore. I did not know Mangalore earlier. I don't belong to this place, but I came for that, and I established a cancer center here. I'm thankful to the Chancellor for giving this opportunity, and Tata Trust, who funded me after my request, in fact, donated me completely up to 70 crores of building work, the equipments, etc. They are already finished, and they are started handing over to me, which I am very thankful to Tata that my dream has at least come true in one medical college where I wrote for all the medical colleges. I am thankful to all of them today. Nevertheless, I have to think of one more group of people who are to thank. That is my family. That is my wife and a daughter who tolerate me every time, because I have never seen many times the sunrise or sunset. I come out by 6, reach probably by 8 o'clock even today. So they are wondering that I become mad even after becoming a vice chancellor. The only thing I know is cancer. So I do that. And I want to continue to do that. And those are the people who saw that my first slide, yesterday, today, and tomorrow, this is what I was told in my MBBS, which I continue to do. Yesterday is but a dream and tomorrow is only a vision. But today lived well makes yesterday a dream of happiness and every tomorrow a vision of hope. This is not the couplet written by me. It is written by Kalidasa. I am only giving the translation. Let us live well to make the tomorrow a vision of hope. Thank you very much. Once again, I thank each and every one of you for the patient hearing, and the organizing committee and the president and secretary for giving me this honor. Have a good day, good night, and God bless.
Thank you so much, Professor Vijayakumar. And I'm sure if it was a live oration, you would have been getting a standing ovation at the moment. I think it's extremely not only inspiring, and the amount of knowledge and experience that you shared, and finally the exciting proposition that you left behind, saying if tomorrow's a chance of hope, and the welcoming stand that you've taken, that anyone who has an interest or has some entrepreneurship idea can always contact you, and that you would be, ready to support something that works. So I think that's extremely inspiring, and I'm sure, I mean, an old timer like me I was mesmerized, and I really, learned such a lot. The youngsters, I hope all of you have also, kind of learned not only how things have, evolved from where they've been evolved, and how tomorrow is still a very, very exciting area. And I'm sure, Professor Vijayakumar, with you leading the charge there at the end of our university, newer things are going to happen. So thank you extremely. There are a lot of messages congratulating you, and so I thank you very much. We do not normally have questions in an oration, but I'm extremely happy and very, very inspired. So thank you again. And to formally thank you on behalf of everyone, I'm calling upon our secretary, Dr. Meryl Anthony, and she will propose the vote of thanks. And we also have a little memento for you. Yes, Meryl.
Good evening, ladies and gentlemen. It is a privilege to be giving this vote of thanks at this 40th edition of an oration organized yearly in the honor of a most beloved teacher, Dr. H.J. Mehta. Dr. Vijayakumar, we are indeed honored to have you, a man of your experience and eminence, to be the orator. We have benefited greatly from listening to your unique and inspiring perspective on surgical oncology, yesterday, today, and tomorrow. Thank you, sir. I thank Dr. Flossie Jaikaran, a much-loved teacher from the anatomy department, for having given us a background to the oration and into a glimpse into the life of Dr. H.J. Mehta. Thank you, ma'am. We are grateful to the management of St. John's National Academy of Health Sciences for their unstinting support of this event through the years. I also thank the members of the executive who have attended this oration, Dr. George, our dean, and the vice deans of the UG and the postgraduate studies, Dr. Anuradha and Dr. John Stephen. A big thank you to all alumni who have logged in from India and from all over the world for attending this oration. Thank you to all the students and faculty of the Academy for listening in. We also have amongst our audience practitioners from the field of surgery and surgical oncology who are from outside the Academy. We thank you very much for your presence. I'd like to place on record our thanks to Huawei, our online alumni engagement platform partners, for taking care of the logistics in setting up this Zoom webinar. Lastly, but not the least, I'd like to thank all my fellow EC members, especially Dr. Maya, our president, for anchoring the program, Dr. Rakesh for an elegant introduction of our eminent speaker, Dr. Sister Diana for the prayer, and lastly, a big thank you to Dr. Benzita Pinto, our academic secretary, for taking care of all the nitty-gritty details that went into organizing this fine oration. Thank you all once again, ladies and gentlemen, and I wish you a good evening.
Benzita, I just wanted to ask you if you have the memento with you, or we have it handed over that we could just, yeah. Dr. Vijayakumar, I do hope this has reached you, and if it hasn't, this is a little memento in appreciation from the Alumni Association, and it's a very, very small token of our appreciation, but thank you again very much. And it was an absolute pleasure to have you as our orator for this year. So thank you all of you.
In a lighter vein, I got the memento even before I gave the oration. Thank you.
Yes, I know, because we had to send it to you. But thank you again. Thank you, everybody, and good night, everyone. Thank you, sir. That was extremely exciting. Yeah. You have a lot of comments, inspiring and amazing contribution to oncology. Then congratulations. Thank you for this inspiring oration. Very, very inspiring. So it was very inspiring. So thank you again, everyone. And good night, Dr. Vijayakumar. Thank you so much.
Thank you, sir.
Thank you.
Thanks,
Thank you. It was
Benjita.
a
Thank
really
you.
wonderful oration, sir.
Absolutely. Thank you.
Very nice, very inspiring.
Very nice, sir. Thank you so much, sir.
Yeah.
Yeah, thank you, Dr. Rakesh,
Thank
for
you, sir.
introducing me. I never knew my CV can be read so well. Thank you.
And I didn't know that you knew Norman Guider so well. I would have personally invited him because it would have been wonderful to have him. I don't know if he was there listening in, but I'm very happy that there was a connection between St. John's and your work. Yeah.
He actually set the ball rolling as far as cancer surgery is
I
concerned.
must tell him, yes, yes. Thank you, Flossie, for being with us and introducing the. Thanks a lot. Good night, everyone. Thanks, Meryl.
Good night.
And
Good night.
thanks, Prithvi. Thank you, Gagan, for doing such
Thank
a
you,
good
Gagan.
job.
Yeah, very went very smoothly. Yeah.
Yes, thanks. We will get the YouTube link. The whole thing is recorded on video. So we will send that to you also, Professor Vijayakumar, so that you can share it with your students and with others. Okay.
Thank you.
Thank you.
Thank
Good
you.
night, everyone. Yeah.
Thank you. Good night.
Good night.
Benzita and Meryl, thank you very much for putting